Thank you very much. So I'm going to try and talk about an awful lot in 20 minutes, like Dr. Lim did. So I'm going to base the talk on the international guidelines of the assessment and management of PCOS that were first released in 2018 and updated in 2023. India had a very prominent role in these guidelines, acknowledging that 1 in every 6 people around the world are from India, and this is a particularly prevalent problem in your part of the world. So having based it on that, I'll highlight some of the key messages, and then we'll go through a case study. So in terms of the condition itself, it's a complex condition, polygenic, there's no one gene, and environment contribute to the endocrinology underlying the condition and the complex clinical features. Indeed, they lead to hormonal changes, so it is an endocrine condition exacerbated by obesity with hyperandrogenism and hyperinsulinemia, leading to dermatological, reproductive, and metabolic features, including high prevalence of type 2 diabetes, as well as gestational diabetes and cardiovascular disease. The features of the condition, including infertility and other factors, lead to psychological impacts. This is not a disease of the ovaries and should not sit only in the management of gynecologists and fertility specialists. And I'm going to say that again at the end. So, knowing that it's a very complex condition and it was very poorly managed, we brought together a consortium from around the world, including the PCOS Society of India and Asia Pacific organisations, as well as the International Society of Endocrinology, to come up with a consistent guideline that was evidence-based and align recognition and treatment of the condition. This guideline took years of my life and in total across the two has 90 systematic reviews and meta-analyses pretty much of all the literature in this condition, including in metabolic complications. The most recent guideline is free, as are all of the resources associated with it, and they have been significantly distributed across India with our close partnership with local societies. So I'm going to focus just briefly on what's new in the diagnosis to make sure we're all talking about the same condition, and then talk about the metabolic features. So originally we had a consensus diagnostic criteria from the NIH that transitioned to a consensus diagnostic criteria in Rotterdam in 2003 that has now been globally updated and accepted as the international guideline criteria from 2018. We now have separate criteria for adolescents and adults, very important to know that, and we have enhanced accuracy. We have managed to show limited overdiagnosis in adolescents and better, more accurate diagnosis in adults. So just in a very simple nutshell, because this condition is very common in your country, is that the most important thing to start with is, do these women have a history of irregular menstrual cycles post-menarche? For the first year, that's normal. But after that, if they have persistent irregular cycles from 1 to 3 years, that's between less than 21 or greater than 45 days, or after 3 years, less than 21 or greater than 35 days. If they have that characteristic, they should be assessed for PCOS. The second characteristic is, do they have clinical features? And that is predominantly hirsutism, but in this part of the world, very much includes acanthosis nigricans. Also scalp hair loss, and it's important that if a woman has menstrual cycle irregularity and those clinical features, she does not need any other tests to diagnose the condition. And that's really important because that's 65 to 70% of people with this condition. If they only have one of these features, then it is reasonable to do a blood test to check for androgens, but please only do the simple ones. The more additional androgens you add on, the more unnecessary tests are done, the less accurate they are, the less specific, and the more people have unnecessary tests for marginally elevated androstenedione or DHEAS. So they only need a free androgen index or a testosterone and sex hormone blinding globulin. So if they have two of those features over here in the orange box, then they have the condition, regardless of their age. If they're an adult and they only have one of those, then you can do either an ultrasound, which if you're going to use it should be transvaginal if that's appropriate, or you can now use a blood test for AMH, and that's in the newest guidelines. So one or the other. If they have two features, they then have the condition. If, however, they are an adolescent, please do not do an ultrasound. Please do not do a transrectal or a transabdominal ultrasound. They are inaccurate. And in adolescents, it is non-specific for PCOS. So we see a lot of overdiagnosis in young women. So if they're an adolescent, they have one feature, re-evaluate them when they get to 20. But if they have one feature, please do not go on and do an ultrasound and an AMH because you will overdiagnose the condition. So if they have those features, and remember that around 70% will be clinical in their diagnosis, then we just need to exclude common conditions with TSH, prolactin, if they're from appropriate ethnic groups, 17-hydroxyprogesterone, and an FSH. There may be some other rare endocrine causes which you will investigate clinically, but they're the only tests that are needed. So in actual fact, diagnosis is relatively easy. In terms of the clinical features, many of these are well accepted, but for our gynecology colleagues and indeed our primary care physicians and for patients, they often fail to understand the metabolic features of the condition. So we know this condition has neuroendocrine implications, it has hepatic implications, we know there are changes in the gut, there are significant differences in adipose tissue, and hyperandrogenism contributes to that. There is changes in skeletal muscle, mitochondria, glucose uptake, there's changes in the pancreas, and indeed in the renal responses. So all of these things lead to an increased prevalence of obesity, just around 2 to 3-fold higher, an increased prevalence of diabetes, which occurs on average 10 to 15 years earlier than comparable women without PCOS, and as of recent evidence, clearly increases the risk of cardiovascular disease. So given that we know 1 in 8 women, and in fact India often is stated to have a higher prevalence of PCOS, but in fact when you look at baseline prevalence, it's not too different to the rest of the world. The prevalence around the world is between 10 and 13%. So we're talking about 1 in 8 women, and yet often the only focus is their fertility. So we're missing the metabolic complications that they have. So the guidelines focused on the fact that we know there is a much higher prevalence of impaired glucose tolerance, of type 2 diabetes in these women, and all of them should have their glycemic status assessed. It should then be reassessed every 1 to 3 years after diagnosis, and it's really important that we focus on prevention. One of the really important things is many people will not screen these women, and we know because we've looked at the data in Australia. Many of us will focus on the fertility features, but not necessarily the screening. And the saddest occasion when we see a woman or a couple who've been through fertility treatment have a pregnancy and no one has diagnosed their type 2 diabetes, they have an HbA1c of 9, congenital abnormalities, and they lose the pregnancy. And this happens repeatedly because our fertility colleagues often don't think about the metabolic features. So they very much need to have those regular screening, even from a young age, and we need to be very diligent before pregnancy. I'm told that preconception screening is easier in India because when a young woman gets married, often you've got a reliable indication that they may want a family soon. That doesn't happen in other parts of the world, for example, where I'm from, where it can be quite some time before conception is planned. But what we do know is there's significant overlap with type 1 diabetes. So 25% of women with type 1 diabetes have PCOS, driven by exogenous high levels of administered insulin, which cause ovarian hyperandrogenism and cause secondary PCOS. We know that obesity does the same. We also know that type 2 diabetes has a much higher prevalence of PCOS. So we know that these are very, very closely connected. So in terms of testing, I'd love to tell you just do a fasting glucose, and you can if that's all that's available and that's what your patients will accept. But an oral glucose tolerance test is much more sensitive. The liver is sensitized by circulating estrogen, and in premenopausal women, whether you're screening for diabetes, gestational diabetes, or glucose intolerance in PCOS, an OGTT is a much more accurate test than fasting glucose or HbA1c. But if you can't do an OGTT, please do something, especially if they're coming up to pregnancy. We also know that it increases cardiovascular risk, and this is controversial for a long time, but it has now been clearly established, and we need to follow them up for cardiovascular risk factors. So in terms of this, it's important to weigh women regularly. We need to be careful of stigma and shame. You can imagine that if high body weight, which is 2 to 3-fold higher in this condition, as is the rate of weight gain, if that is linked to poor fertility outcomes, which it is, BMI and PCOS independently both significantly impact fertility, there is a fair degree of shame and concern for the women that are involved. So it's very important that we manage that stigma and blame when we're communicating this. It needs to be around optimizing their health as best we can. Focus on detecting and preventing obesity, diabetes, and cardiovascular disease. Make sure we're screening regularly because they get diabetes and they get it young. Make sure we're monitoring blood pressure because they get hypertension. Lipids do not need to be checked regularly if they're not abnormal at baseline, but definitely hypertension and glucose. Lifestyle works for preventing weight gain. If anyone in this room can prove to me that lifestyle is an effective, standalone, sustainable intervention for a woman who presents with a BMI over 27 to 30, then I would love to see how they do it because the evidence does not support it. So our lifestyle focus should be on preventing the rapid rate of weight gain we see in this condition. And it's really important that that's the goal, but not suggesting that they will actually be treated effectively by lifestyle alone. We are setting them up to fail. Metformin is used extensively in India, one of the first countries in the world to actually have an indication for metformin in PCOS, and much of the world is catching up now, but congratulations for getting that over the line. It does limit weight gain. It also can be useful for diabetes prevention, and we know it does induce ovulation, improve cycles, and can improve infertility. It is not as effective as the other agents, but if you have a woman who's a bit younger, who has some time to wait, especially because the indication is that metformin probably takes longer, then it's a very reasonable, low-cost, safe first-line treatment. It is also then very incumbent on us to consider other medical and surgical obesity options for those over 30 and arguably in this part of the world over 27. Just an acknowledgement, an oral glucose tolerance test is important. Please don't measure the insulin level. At the moment, it has almost no clinical relevance. If I walk into my lab, having not eaten breakfast, I go and walk 200 meters, sit down, have my blood test done, my insulin level will be completely different to if I sit there for 15 minutes before I have the blood test drawn. And you can't do a clamp study like we do for 6 hours on women in clinical practice. If they have PCOS, they have insulin resistance. Just focus on what you'll treat. So essentially for diagnosis, most of the time you don't need a test, but if you do, just total testosterone and a free androgen index, and only in adults if needed, an ultrasound or AMH. The exclusion test we've discussed, all of them should have an oral glucose tolerance test. They can have lipids once, they do not need insulin. And then the other thing is we need to remember that given 80% of these women have psychological distress, and this is the area they say we manage the worst, it's really important to make sure we screen for that. Just another factor, these women are really high risk in pregnancy, but nobody thinks about it. It's not in most of the obstetric training, it's in gynecology training, but it turns out they have much higher gestational weight gain, higher early and late miscarriage, much higher gestational diabetes, much higher hypertension and preeclampsia, intrauterine growth restriction, and despite obesity and GDM, they have small babies, not large babies, because they have placental vasculature challenges. They have more preterm delivery and more cesarean section. If there was any other condition that caused all these risks in pregnancy, the obstetricians would be all over it. And yet around the world, almost none of the women with PCOS are even identified in pregnancy because, again, it's seen as an infertility disorder. So if you are caring for a woman who has PCOS and impaired glucose tolerance or diabetes and is going into pregnancy, you need to make sure these things are considered. So just quickly, in terms of treatment, these women have 80% higher depression and anxiety, an 8-fold higher suicide rate. And yet we often don't necessarily understand that or provide empathy in our care. And it's really important to do that, especially if we're going to look at management of weight and metabolic features. Be careful about weight stigma. There is no diet that is a miracle. There is no lemon diet. There is no high carb, low carb, high protein, Mediterranean diet. There is no one diet that is better for PCOS that has been proven. A healthy diet that follows recommendations that tailor to the patient's need is really important. And the most important bit is to get the indication right, which is to prevent weight gain and keep them healthy, not as a sole treatment for obesity. The type of lifestyle intervention I've just mentioned. So in terms of medical therapy, there's pretty limited evidence specifically in PCOS. The population level advice applies, but there is some randomized control trials that have finished that look impressive, that are not yet published, including in adolescents. And essentially the benefits are largely the same, but you've got to be very careful because it's not appropriate to use in pregnancy. And the moment you stop it, their rate of weight gain is dramatic. And that occurs then during pregnancy. So you can have 30 to 40 kilos of gestational weight gain if they use these things preconception. So they're almost certainly not going to be the answer in terms of preconception care, but after pregnancy, they may be reasonable. Metabolic surgery is quite effective in this condition. In fact, given that these are often young women, it lasts 20 years. If you look at the long-term cost of metabolic surgery, it's almost certainly cheaper than most of the medications at the moment before they come off patent. It can reverse most of the features of PCOS, and there was a recent paper in The Lancet with a randomized control trial looking at this, and there's some long-term registry data coming out that are very encouraging. So we shouldn't dispel this given that these women are quite young, but if they're going through pregnancy, we need to be aware that there are some complications. Just a word, we would love to think metformin is great in pregnancy. The problem is, for some reason, it does not prevent gestational diabetes. And there's some more definitive evidence coming out about that in all populations in pregnancy. There's something about the insulin resistance in pregnancy that metformin does not work for. It does not prevent late miscarriage, hypertension, preeclampsia, or macrosomia. It can reduce preterm birth, and it does limit excess gestational weight gain. So it's not unreasonable to consider, but just make sure you know why you're using it. So very quickly, we've got a 16-year-old who had menarche at 13. She was South Asian by birth. She's had oligomenorrhea for the last few years. She usually has around less than 4 cycles a year, and her BMI is 27. She presents with acne, facial, and body hair growth. Now, often that's all that will be addressed is just her hirsutism. She's often just put on the pill, sometimes not even investigated and diagnosed. So it's important to consider her dermatological concerns because that's what she's presented with. But it's also important to consider a long-term reproductive plan about how you keep her as healthy as possible. Her metabolic features, so she needs appropriate screening and a prevention plan, and also her psychological factors. Sorry, I should note that by definition, because she has irregular cycles, and also has hyperandrogenism, she does not need further investigation other than excluding causes. She has the diagnosis. So it's important to think about all these things when we assess her. We've just published a very large longitudinal case study in the American Journal of Obstetrics and Gynecology showing if you fail to diagnose these girls in adolescence and you fail to tell them they have this condition, you just put them on the pill or you go and get them treated for their hyperandrogenism, they are more likely to remain childless and they are less likely to achieve the family size they want, and their outcomes long-term are worse. So it's really important we don't just look at their immediate problem and actually make the diagnosis. So she gets the diagnosis, we treat those particular issues and screen her, and she continues to present. And so actually she's very concerned about taking the pill. And this is increasingly common based on social media misinformation because the pill is seen to be the villain. And so we have then long discussions about the role of the oral contraceptive pill, its efficacy. It has to be oral. It is actually the first pass hepatic effect that gives you the benefit because it puts up the sex hormone binding globulin and reduces the hyperandrogenism. Other forms of contraception don't do that, so it's important to recognize it's the oral impact that is useful. In PCOS, we do not frame it as a contraceptive unless we're looking for contraception. We frame it as a hormonal treatment for hormonal endocrine disorder, which often makes it much more acceptable, especially for mothers of adolescents in that context. So again, we would consider what her dermatological concerns are, her reproductive life plan, for example, bringing up the fact that planning a family earlier would be preferable, so she's not addressing age, BMI, and PCOS in her infertility. Screening her again for her metabolic and psychological factors. Then she comes to you when she's 30. She's unable to get pregnant. She ceased the pill 9 months ago and she's not having any cycles, and her BMI has gone up to 30. Now, if she's not cycling, she's not ovulating, so it's unlikely that she's going to conceive, and it's worth considering simple interventions. So again, considering her reproductive status, her reproductive life plan, thinking about preconception screening for her metabolic status, providing education on her options, and then referring her on for fertility treatment if appropriate. Really important to get those metabolic screening and lifestyle factors in there at that time. Following metformin and subsequently letrozole, she gets pregnant and she presents at that time with extreme tiredness. Again, a really good opportunity for you to highlight those risks in pregnancy and focus on screening and prevention. So I'm going to just very briefly now touch on, and that was really to emphasize the diverse impact of the condition and the fact that it has lifelong implications. And as physicians, and we often see our patients longer term, and we have the opportunity to make sure we cover across those. Just to support you in your journey, because it is complex, there are very significant free resources for you, but also for your patients available. And these are in multiple languages. I believe we do have Hindi there now. The app Ask PCOS is free. It has resources in Hindi. It is used in 195 countries and has been accessed by over 1 million women. And it is used extensively in India. So we would encourage you to get your patients involved, and it has had patient input from India. That's the QR code to get it into any of the resources that are again free. And what's next? We are in the middle of an international initiative to change the name of the condition, because it is not, there are no cysts on the ovaries, they're follicles. It is not an ovarian disease, and it is stuck in a gynecology box because of its name. 91% of the 7,000 health professionals and women we engaged want to change the name of the condition. It looks like endocrine, reproductive, and metabolic are the three most common terms that are likely to end up in there, but it will much more clearly become the bastion of physicians over time. And I hope you'll join with me in improving the diagnosis and care of these women. Thank you.